A young woman lies unconscious on a hospital bed, her body convulsing as doctors inject massive doses of insulin into her veins. For the next hour, she remains in a deep coma while medical staff monitor her vital signs. When she finally awakens, they will repeat the process tomorrow and the day after that, and every day for the next 2 months. This was insulin coma therapy, a treatment that psychiatrists in the 1930s believed could cure schizophrenia by deliberately putting patients into life-threatening comas. Thousands underwent this procedure. Many never woke up. Those who did often suffered permanent brain damage that doctors mistook for improvement. This is the story of one of medicine's most dangerous delusions. In 1927, Austrian psychiatrist Manfred Sackel made an observation that would change the landscape of mental health treatment for the next 3 decades. While working with diabetic patients who also suffered from mental illness, Sackel noticed that some of his patients seemed more lucid and calm after experiencing accidental hypoglycemic comas caused by insulin overdoses. Instead of recognizing this as a dangerous side effect to be avoided, Sackel saw an opportunity. Sackel's background was typical of psychiatrists of his era. Born in 1900, he had received his medical training in Vienna during the aftermath of World War I, when European medicine was struggling to rebuild itself after the devastation of the conflict. The psychiatric field was particularly primitive, with treatments based more on tradition and guesswork than scientific evidence. Sackel theorized that deliberately inducing comas through insulin injections could reset the brain and cure mental illness. He began experimenting on patients with schizophrenia, morphine addiction, and other psychiatric conditions, carefully documenting what he believed were remarkable improvements in their symptoms. His early reports described patients emerging from comas with clearer thinking, reduced hallucinations, and better emotional control. The theoretical foundation for insulin coma therapy was based on several misconceptions about brain function that were common in the 1920s. Sackel believed that mental illness was caused by toxins that accumulated in the brain, and that insulin comas could somehow flush out these harmful substances. He also theorized that the shock of near-death experiences could reorganize disordered neural pathways. The medical community of the 1920s was desperate for effective psychiatric treatments. Mental hospitals were overcrowded warehouses where patients were often confined for life with little hope of recovery. Traditional treatments consisted mainly of restraints, cold baths, and occupational therapy. When Sackel announced that he had found a cure for schizophrenia, the psychiatric establishment embraced his work with enthusiasm that bordered on religious fervor. The timing of Sackel's discovery coincided with broader changes in medical practice that made ICT seem scientifically credible. The discovery of insulin itself in 1922 had been one of medicine's greatest triumphs, saving countless diabetic patients from certain death. The idea of using this wonder drug to treat other conditions seemed logical to physicians who had witnessed insulin's remarkable effects. Insulin coma therapy, or ICT as it became known, spread rapidly across Europe and then to the United States. By the late 1930s, major psychiatric hospitals in Vienna, Berlin, London, and New York had established ICT units. The treatment was hailed as a breakthrough comparable to the discovery of antibiotics, and Sackel was celebrated as a medical pioneer who had finally brought scientific rigor to psychiatry. The procedure itself was as complex as it was dangerous. Patients would be selected based on their diagnosis, with schizophrenics considered the best candidates for treatment. The therapy required extensive medical infrastructure with specialized units staffed by teams of doctors and nurses trained specifically in ICT protocols. Each treatment session demanded constant monitoring and emergency preparedness. The selection criteria for ICT patients revealed important biases that would later undermine claims about the treatment's effectiveness. Doctors typically chose younger patients with recent onset of symptoms, good physical health, and supportive families. Chronic patients, elderly individuals, and those with poor prognoses were usually excluded from treatment. The process began early in the morning when patients would receive progressively larger doses of insulin injected directly into their bloodstream. The initial dose might be 15 units, but this would be increased daily until patients were receiving 100 to 150 units, and sometimes as much as 450 units. For comparison, a diabetic patient might use 20 to 40 units per day to manage their condition. The massive doses used in ICT were designed to overwhelm the body's glucose metabolism and force the brain into a hypoglycemic coma. As the insulin took effect, patients would experience the progressive symptoms of severe hypoglycemia. They would become confused and disoriented, then drowsy and unresponsive. Their blood sugar levels would plummet far below the range necessary to maintain normal brain function. Within an hour, most patients would slip into deep comas, their bodies often convulsing as their brains were starved of the glucose needed for basic cellular processes. The medical staff would carefully monitor each patient's vital signs during the coma phase, watching for signs of impending death or irreversible brain damage. Heart rate, blood pressure, and breathing patterns all provided clues about how close the patient was to the point of no return. The goal was to maintain the coma for exactly the right amount of time, long enough to achieve the supposed therapeutic benefit, but not so long as to cause obvious permanent damage. After 1 to 2 hours in a coma, medical staff would begin the revival process. Glucose would be administered through various routes, intravenously for the most critical cases, orally for patients who could swallow, or even through nasal tubes. The transition from coma back to consciousness was often violent, with patients experiencing severe convulsions, profuse sweating, and confusion as their blood sugar levels rapidly normalized. The complete course of ICT typically involved 50 to 60 individual coma sessions spread over several weeks or months. Patients would undergo this ordeal daily, with their bodies and brains repeatedly subjected to the trauma of near death and revival. The cumulative effect was supposedly therapeutic, though the mechanism by which repeated brain damage could cure mental illness was never clearly explained. Hospital records from the ICT era reveal the true human cost of this treatment. The death rate was officially estimated at between 1 and 5%, though many historians believe the actual mortality was higher due to underreporting and indirect deaths caused by the treatment. Patients died from prolonged comas that could not be reversed, from cardiovascular complications during the insulin shock, and from aspiration pneumonia when they vomited while unconscious. Those who survived often suffered consequences that were only recognized years later. Many patients experienced significant weight gain due to the repeated glucose loading required to reverse their comas. Others developed cognitive impairments that were initially attributed to their underlying mental illness, but were likely caused by repeated episodes of brain hypoxia. Some never fully recovered their pre-treatment level of functioning, though doctors often interpreted this decline as evidence that the treatment had worked by making patients more manageable. If you want to understand how medical treatments can become widely accepted without proper scientific validation, and why modern clinical trials exist to protect patients from dangerous experimental procedures, make sure to subscribe because we explore the darkest chapters of medical history and the lessons they teach us about the importance of evidence-based medicine. The scientific justification for ICT was remarkably thin, even by the standards of 1930s medicine. Sackel's original theory suggested that insulin comas selectively destroyed diseased brain cells while leaving healthy neurons intact. This hypothesis was never proven, and subsequent research showed that hypoglycemic brain damage was actually random and widespread, affecting both healthy and diseased tissue indiscriminately. Early success stories were based on subjective observations by doctors who were heavily invested in the treatment's success. Patients who seemed calmer after ICT were counted as cured, even if their apparent improvement resulted from brain damage that had reduced their overall cognitive function. The selection criteria for treatment also introduced significant bias, as only relatively healthy patients with good prognoses were typically chosen for ICT, making the treatment appear more effective than it actually was. Independent studies conducted in the 1940s and 1950s began to reveal the true nature of ICT's effects. Autopsy examinations of patients who had died during or after treatment showed extensive brain damage, particularly to the white matter that connects different regions of the brain. Animal studies confirmed that repeated insulin comas caused irreversible neurological damage that bore no resemblance to therapeutic intervention. Critics of ICT began to emerge within the psychiatric community, though their voices were often drowned out by the enthusiasm of treatment advocates. Some physicians compared ICT to a physiological lobotomy, noting that both treatments seemed to work by damaging the brain rather than healing it. The similarity was not coincidental. Both procedures were based on the assumption that mental illness could be cured by destroying the brain tissue responsible for symptoms. The decline of insulin coma therapy began almost as soon as alternative treatments became available. In 1933, Hungarian neurologist Ladislas Meduna introduced metrazole-induced seizure therapy, which was considered safer and easier to administer than ICT. Electroconvulsive therapy, developed in 1938, offered similar benefits with even fewer logistical complications and lower mortality rates. The death blow to ICT came with the introduction of chlorpromazine and other antipsychotic medications in the 1950s. These drugs could control psychotic symptoms without requiring patients to be repeatedly placed in life-threatening comas. The pharmaceutical revolution in psychiatry made ICT not just obsolete, but obviously barbaric in comparison to chemical treatments that worked without causing brain damage. By the 1960s, insulin coma therapy had been abandoned in most developed countries. The few hospitals that continued using ICT into the 1970s were generally considered behind the times, clinging to outdated practices that had been discredited by both scientific evidence and practical experience. The treatment that had once been hailed as psychiatry's greatest breakthrough was relegated to the dustbin of medical history. The ethical implications of ICT extended far beyond its medical ineffectiveness. Most patients who underwent the treatment had no meaningful understanding of what they were consenting to, assuming they were asked for consent at all. The concept of informed consent was not well developed in the 1930s, and psychiatric patients were generally considered incapable of making medical decisions for themselves. Family members who authorized ICT for their relatives were told they were choosing a cutting-edge treatment that offered the best hope for recovery. They were rarely informed about the significant risk of death or permanent brain damage, and certainly never told that the supposed benefits of the treatment were based on flawed observations rather than rigorous scientific study. The legacy of insulin coma therapy serves as a powerful reminder of how medical treatments can become widely accepted without adequate evidence of their safety or effectiveness. The enthusiasm of individual practitioners, combined with desperation for effective treatments, created a perfect storm that allowed a dangerous and useless procedure to flourish for decades. Modern medical ethics and clinical trial protocols exist largely to prevent another ICT-like disaster. The requirement for informed consent, independent ethics review, and controlled studies with proper control groups all stem from lessons learned during the era of experimental psychiatric treatments. The tragedy of ICT patients who suffered and died for no medical benefit helped establish the principle that good intentions are not sufficient justification for risky medical interventions. The stories of individual ICT patients remain largely untold, as many families were too ashamed to discuss what had happened to their relatives. The stigma of mental illness, combined with the trauma of having authorized a treatment that caused more harm than good, led to decades of silence about the true human cost of insulin coma therapy. Hospital records from the ICT era reveal glimpses of these personal tragedies. Young women who entered treatment with manageable symptoms and emerged as permanent invalids. Men who died alone in insulin comas while their families waited for news of miraculous recoveries, and countless patients whose suffering was prolonged rather than relieved by medical intervention intended to help them. The doctors and nurses who administered ICT generally believed they were providing beneficial treatment, but their good intentions could not overcome the fundamental flaws in Sokolo's theory. The medical community's willingness to embrace ICT without demanding rigorous proof of its effectiveness demonstrated how professional enthusiasm and institutional momentum could override scientific skepticism. The last recorded use of insulin coma therapy occurred in the Soviet Union in 1980, more than 50 years after Manfred Sackel first began inducing comas in psychiatric patients. By then, the treatment had been thoroughly discredited in the West, but some Soviet psychiatrists continued to believe in its effectiveness despite overwhelming evidence to the contrary. The final ICT patient, a young schizophrenic woman whose name was never released, slipped into an irreversible coma during her 15th treatment session. She died 3 days later, becoming the last known victim of a therapy that had claimed thousands of lives in the name of medical progress. Her death marked the end of an era, but it raised a troubling question that echoes through modern medicine. How many treatments we consider safe and effective today will be viewed as barbaric experiments by future generations?